So though we have moved forward, instead of only a Zoom meeting, we now have a hybrid meeting, and we are fortunate to have quite a few guests here present in the seminar hall. The Secretary IAP Delhi, Dr. Pankaj, is with us. The President has not been able to make it here, so he'll be joining online. And on behalf of Center for Child Health, PL Kapoor Super Specialty Hospital, I welcome you all, and I now request Dr. Pankaj Garg, the Secretary, to take over and conduct the meeting.
Good afternoon, friends. I am Dr. Pankaj Garg, Secretary of IAP Delhi, and I thank Dr. Bhasin for hosting this meeting. This year has been not the best years for us, like pre-COVID. So we had certain meetings which were conducted physically and others meetings which are online. So at every time we request or we ask the host center whether they are interested in doing physical or online meetings. Dr. Bhasin said they want to do online meeting, which is always welcome because then we are able to see each of you face to face, and it is always more interactive and more understandable. At the same time, a lot of people are not able to join, so this meeting is actually hybrid. People right now, there are around 10 people who are online, and all of us are already there. Before I start this meeting and the program starts, just to mention that as every year, we have our annual conference, which is PCNI, the Pediatric Conference of North India, which this year we are doing at Hayat Centric, Janakpuri. It is on 29th and 30th October. So as the promise of PCNI has been, it's a 2 days event, which is full of academic as well as extra academic activities. This year, the program is a little different in the way that it is a combined type of meeting in which workshops are part of the main meeting. So first day, we'll be having 5 workshops from 9 to 12, short workshops. And then even the papers, which normally are presented in the annual day of IAP Delhi, will be presented in the PCNI workshop, PCNI conference itself. So block your dates and request your friends, your colleagues, your PG students who want to participate to register for the conference. So with this, now we start the program. And I request Dr. J.S. Bhasin, Director and HOD Pediatrics, to chair the session, which is being held by Dr. Ishita Bhardwaj. And the topic is marital harmony is essential for professional symphony. So I request Dr. Bhasin to introduce the speaker and the topic.
Thank you, Dr. Pankaj. It's my privilege to introduce the guest speaker for today, Professor Dr. Ishita Bhardwaj. She is an associate professor in the Department of Psychology at the University of Delhi. And she's been here for over a decade. Before that, she had experience at working at the Allahabad University and the Banaras Hindu University. The last 2 years have been really upsetting to us as far as our personal lives goes. Professional, you all know, but even our personal lives have been really upset. The family dynamics have changed. People have been forced to live together for longer hours. The children have been forced to stay at home. So it has added to a lot of stress. Newer dynamics have developed. Maids were not available. So we found men who never entered the kitchens and had nothing else to do learning how to cook. But the domination of the ladies over the kitchen has also partly eroded. So there has been a lot of flux. And that's why we tried to choose a topic which affects all of us, our personal lives as well as our professional lives. And we thought who best to enlighten us on this topic than Professor Ishita Bhardwaj. She is an expert in marital relations, family dynamics, women-oriented topics. And these 2 years, though we have been very forced to be confined to our homes and restrict our practices, she has been very busy. And in these 2 years, 4 of her students have completed her PhD, and she has managed to have 8 new publications during these 2 years. And she has brought out a new book also. So without wasting more time and trying to give her as much time as possible, I'll now request Dr. Ishita to please take the dais.
You can see her, but can't see the presentation.
So till we are setting this, a warm welcome to all of you, to Dr. Deepak and Dr. Garg, and a special note of thanks for Dr. Basim. I'm truly and genuinely grateful, humbled to be invited in addressing a concern like this, because usually this concern, assuming that all of us in some or the other capacity has a relational experience, this is not something new to us, but we rarely talk about it, and we rarely give few minutes and few hours in thinking through what is going wrong or what is happening in my relationship. So it's genuinely a very serious concern, keeping the pandemic in mind, but also the cultural flux with which all of us are going through, the transition from collective to individual, the transition from living in a united way, in a unified way, to a more individualistic way, because each one of us, whether we are male or female, are learning to assert our positions professionally as well. And with this change, how and what is happening in the relational space is something which calls for a few minutes of address. And as pediatrics, as a profession, since your functioning is to look after the development and holistic well-being of children, longitudinally, developmentally, you are well aware that the psychosocial environment plays a very important role in as a catalytic factor in the development of it. And this psychosocial environment, we often take it as a natural habitat, but it's not that natural. So this is what I wish to state and bring forth through my few minutes of sharing with you. But before we begin, I would quickly want all of you to pick up your pen and just write a word. Someone I overheard telling to Dr. Basim, topic kya aapne select kiya tha with the word symphony and harmony. तो ये दो शब्द जब आपके सामने आते हैं, आपके पास क्या क्या शब्द आता है? Just a free association of 1 minute. Symphony and harmony.
Just click here.
Just few words. I don't have to think and write. Okay. Very good. Yes. So, randomly, word symphony, what it
Music.
music, fun, Family. Okay. Happiness in family. And tuning, music. Yes. Anything else? Mutual understanding. So, with the word symphony, with the word symphony. And harmony. So more of peace, tranquility, satisfaction.
All good words.
All very good words. End of the day, it's a why, you know why? Because interestingly, these two words are not from an intellectual field. They are from the discipline of music. They are from a discipline where there is intrinsic flow of energy and creation, unlike the discipline you and I are engaged with. So symphony, technically, if we say, it means a long piece being created using different instruments. It's a long, and all of them merge in such a manner that you cannot make out which sound is unique or which sound is coming out of it. So that is the term symphony. When we talk here about the literal meaning and moving from here to the psychological meaning of symphony and harmony, this is precisely what we expect our relationships to be. Helping us to evolve as individuals, helping us to give our best in terms of potential, and also helping us to expand structurally and socially. That is the general expectation. Marriage as an institution has been an old age practice, and we don't need to talk about it because across cultures, across civilizations, we get to see how the caveman to the modern man has evolved with rituals and practices in marking something, a ceremony called marriage. So marriage vis-a-vis relates to family structures. If I were to quote a sociologist, Duncan Michel, he says marriage is nothing but an assurity of a relationship between two or more individuals, and that relationship precisely is a sex relationship, endured and lived even after gestation period until the child is grown up. So it's not just a gestation period. This definition hints at what the cavemen used to do. The cavemen used to drag women for mating and for procreation. There was no marriage, there was no ritual. However, the sense of possessiveness in the emotional trail was observed even in cavemen. So have we really changed from prehistoric to our current times vis-a-vis our emotion? That is a question we need to think about. Now, empirical research on marital conflicts, they give you a whole list of issues, needless to go through them again. But if I were to categorize, it comes precisely from certain lack, because they look from a deficit model. The lack in terms of commitment. So when there is a lack of commitment, what we get to see as problem is sexual incompatibility, frigidity, infidelity, etc., etc. I call it aberrations. Why that lack is taking place is something as researchers we don't look into. We only look into the problem side. Then there is the problem of communication. How do I open up to my partner? Because oughts and shoulds, they really drive us crazy. What I should be, what the person should be, how I should behave, what the person should behave. And we are juggling with multiple identities, sir and madam. And especially being the professionals, we have this professional self, we have this personal self, we have our social self, and there is the larger cultural self that is really, really fueling us and making us believe this is what we are. So when there is the communication problem, when this fabric is lost, then there is emotional abuse. There is a suppressive silence, which often we think is good, but it is like putting problems under the carpet. Let's not talk about it. And then we take on this garb of being busy bee, the status quo, very busy. Let me put myself in the profession. Let me do the best, etc. Financial problems have been highlighted. Social problems have been highlighted. But for your concern and something which could matter in your profession, the overall development of the child, because the child is absorbing it at a very subliminal level. Child is absorbing it at a unconscious, unknowingly, which in ways is shaping his understanding of social equation, social partnership. So if these are the problems, if these are the conflicts that has been highlighted, then what is the problem? This is a quote I have used by Michael Hyatt, a very famous American author. We look up to American authors, ना, क्योंकि वो हमें बताते कैसे जियो. तो ये बता रहे हैं marital relationship पे, nothing will undermine your effectiveness as a leader faster than a bad marriage. Now, why I took this quote, I could have taken an Indian quote as well, because a developed country's developed model is suffering with very fast rate of marriage collapse. And not just marriage collapse, but also the collapse of relational compatibility. And here is someone who's wanting to highlight this kind of social fabric are going to produce bad leaders. This kind of social fabric are going to produce bad civility. So this is one thing which we need to understand. Now, if we were to identify the problem, what is the problem? Not empirically, but actually what is happening in the relational space that seems to be problematic. The first I highlight is culture as central. None of us, with due respect to our education, exposure, knowledge, can be away and untouched by the cultural fabric. तो पुरुष होना क्या होता है और स्त्री होना क्या होता है, ये शिक्षा से पहले हमें हमारी संस्कृति बताती है, हमारे परिवार की संस्कृति, हमारे समाज की संस्कृति. और ये संस्कृति ना सिर्फ किसी बाहर के परिवेश में ऑपरेट कर रही, हमारी इमोशनल स्टेट में भी ऑपरेट कर रही है. The emotion which we experience takes place in the personal space, but the impact and the factors influencing my emotion is taking place outside. So what I watch, what I see, what I hear, the kind of films I watch, the kind of music I listen, the kind of conversations I engage in, each and every material, each and every content is impacting your emotional state. So how this is so important to be aware of. Living in denial. हम किस तरह के रोल मॉडल्स को देखते हैं, किसके जीवन में नाखुशी नहीं होती है, सभी परेशान हैं. ये सोच कई दफा अपनी परेशानी को अंडरमाइन करते हैं और उसे उस कैटेगरी में डाल देते हैं कि ये इनसॉल्वेबल है. ऐसी परेशानियां आपके विवाहित होने में या पार्टनरशिप होने में एक कंटिंजेंट है, जबकि ऐसा है नहीं. ये हमारी इनकॉम्पिटेंसी होती है कि हम अपनी समस्याओं को देखें कैसे, इसके किसी ने हमें तरीका नहीं बताया. तो या तो समस्या दिखती है या नो प्रॉब्लम स्पेस दिख रहा है. Where do I stand between the two? That makes us, many of us, live in denial. वहां से आता है guarding one's emotion. तो आप कितनी दफा अपने क्रोध को या अपने गुस्से को और कैसे हैंडल करते हैं, आपसे बेहतर कोई नहीं बता पाएगा. उस पर से अगर आप एक महिला हैं तो अपने गुस्से को आप कैसे हैंडल करते हैं, और अगर आप एक अच्छे पुरुष हैं तो अपने गुस्से को कैसे हैंडल करते हैं, और उस हैंडलिंग का मैकेनिज्म आपके साइकिक स्पेस में क्या असर दे रहा है, that is something which happens when we are guarding our emotions. So in guarding our emotions, we are not aware of it, we disengage and we suppress. That is problematic. That leads to all kind of spillover. तो अचानक एक दिन जो है वो तूफान सा कभी वर्क प्लेस में खड़ा होगा, कभी आपके अंदर खड़ा होगा, कभी बाहर खड़ा होगा. The recipient may change. It could be my partner, it could be my colleague, it could be my child, it could be my patient, but this is happening, and this is happening in a recurrent basis. What do I do with it? There is this also problem because we are taught to respect our partners. We are taught to have mutual trust, but we are never given space to develop that respect, to go wrong with it, to discover how do I respect each other. So the shift from idealism to reality is quite a shock, quite a jerk for many of us. क्योंकि हम शादीशुदा होने में उम्मीद करते हैं कि ये अब 7 जन्मों का बंधन होगा और सब कुछ ठीक हो जाएगा, बैक ऑफ द माइंड. और पढ़े लिखे अगर हैं तो हम कहीं इसको लेके सिनिकल भी होते हैं कि जरूरी नहीं कि सारी जिंदगी साथ रहना. बट ईदर वेज में हमारे इमोशनल स्पेस में जो डैमेज होगा उसका हमें अंदाजा नहीं होता. इंटीमेसी एंड इट्स पैराडॉक्सेस, ये जो issue of infidelity आता है, often with my clients I try to help them realize, let's not talk about the other partner, the other woman or the other man. Let's talk about you. What have you been feeling? Why in marriages we look into these aberrations so moralistically? How can we develop a more human way of looking at it so that we open up, we talk about it? We understand that. Past versus future. Now, this is where your profession and mine again comes into play, because the cultural baggage, the lived life of the parents and the social environment is very much present in the well-being of our patient, of our client, whoever is the recipient they are trying to study. And we still do not have any mechanism of measuring that, to what extent the child is damaged or to what extent the child is influenced by these other factors. Clutter versus space. Sometimes we appear to be very organized, but in our minds and in our emotions, we could be very ruthless and everywhere. Where do we open up? Where do we reorganize ourselves? David White, another contemporary thinker, an American thinker, says there are 3 marriages which we must keep in mind. We think we are marrying one person, but it is marriage with work, with self, and with relationship. And if we draw a pyramid and put, so if I ask you to draw a pyramid, probably you'll put self on top, relationship and work on the baseline. But this could change, and this keeps changing. Avoiding oneself, neglecting oneself is bound to impact your relationship, is bound to impact your work as well. And the most important relationship is the one with yourself. How are you engaging with it? Unfortunately, our entire training is relating with the outside world. There is no training for the inside space. This is, I could have listed, because as a practitioner, I do not believe in being prescriptive, because each one of us have the repository of our experience. तो आपके जीवन में आकर किसी और का बताना कि ये करिए सब ठीक हो जाएगा is not my way of dealing. This is a painting, and it's a painting by Richard Long, 1989. It's a painting of his journey from Atlantic to Mediterranean range, and how these water lines, they keep dripping out. So if you read the quote, he says, each day a water line poured from my water bottle along the walking line. And it was a long walk. This painting has the essence of being in repetition, doing everything in a manner where you experience solitude. And there comes the first way out from the problem, listening. This is not just the physiological listening where sound bites reach the auditory canal. This is listening to oneself and listening to the other. Most often, when we are in an argument or when we are in a space of confrontation, we are actually not listening, because we have our ideas, we have our views, we have our values taking over to what I want to say and how I want to assert. This is a practice, sir and madam, that really benefits, if not anything else, your quality of living. How do you listen? There is another thing that helps in marital space is curiosity, something which we very soon lose, because the moment we come to know, मुझे पता है तुम क्या हो, मुझे पता है मैं क्या, मुझे पता है वो क्या है. पर अगर हम इंसान हैं और अगर हम डायनेमिक हैं, और आप तो मुझसे बेहतर फिजियोलॉजी और सेल और सब कुछ जानते हैं, are we the same? Because we are also evolving. If not evolving just physiologically, we are also evolving emotionally. So this curiosity is so important, and that helps you to discover. Discover who? Not just the other, but discover yourself in this space. Bringing a perspective. This bringing us perspective is different from the larger cultural perspective, which we want to believe, but we feel betrayed. We feel this perspective has not helped us. Can we do some stock taking? And can we change our ways of looking? And this is where metaphors play a very important role. जब आप कहते हैं जीवन एक संघर्ष है, तो आप अपने लड़ाकू पने को जस्टिफाई कर देते हैं, क्योंकि संघर्ष में तो हर आदमी लड़ रहा होता है. पर जब आप कहते हैं जीवन एक यात्रा है अपने आप से, तो उस यात्रा के अलग अलग कोनों में उसको स्वाभाविक तरीके से लेने की संभावना आप क्रिएट करते हैं. तो आपके मेटाफर्स जो है प्रतिबिंब, वो बहुत महत्वपूर्ण योगदान रोल प्ले करते हैं जब आप अपने साथ संवाद में होते हैं. रीजनेबल अप्रोच. नाउ दिस रीजनेबल वर्ड इज वन मिसयूज्ड टर्म, क्योंकि रीजनेबल का अर्थ हम अक्सर सोचते हैं लॉजिक से, पर रीजनेबल का मतलब होता है जब आप इन मोमेंट किसी को एड्रेस कर पाते हैं एंड यू आर एबल टू अप्लाई रीजनिंग इन दैट मोमेंट. दैट इज रीजनिंग. ठीक है. लॉजिक में क्या है? लॉजिक में यू आर गोइंग बाय अ फॉर्मूले. रीजनिंग में क्या है? यू आर मोर प्रेजेंट इन द मोमेंट, allowing the process to take place. And when you do that, then you will be less conclusive. You will be less suffering with heightened emotion. You will be less into a space to judge and analyze the other. So it helps. Creating space for redesiring our partners. Now, this is a very important area, which is rarely talked, especially by professionals and assertive individuals, क्योंकि इस बात को एक्सेप्ट करना या इस बात को अपने संभावनाओं में लाना कि इसको कैसे हम रिकिंडल करें, क्योंकि डिजायर का एक बहुत बड़ा पक्ष हमारा एक्सपेक्टेशन से हम जोड़ देते हैं. और हमें लगता है जब कोई चीज मिल जाती है तो एक टेकन फॉर ग्रांटेड अप्रोच आने लगता है. And desire is just the opposite of it. So if other three are present, you don't have to make any extra effort in developing the desire. It's the desire in itself, this desire for life. So from here, we come on to this wonderful quote by Rilke, another literary person, a philosopher, who says that it is quite a myth to believe that togetherness only happens when we merge in each other, because that's practically not possible. We are two individuals. So then how do we live? He says, when you realize that there are two different streams, you learn to respect solitude. You give space to other. And you allow the other to grow in his or her space. So it is not to create a quick commonality. और हम ये अक्सर assertion करते हैं, तुम मेरी जैसी हो जाओ या मैं तुम्हारे जैसा हो जाऊं, प्रॉब्लम सॉल्व हो जाएगी. But it is the germination of a problem. So a good marriage is one in which each partner appoints the other to be a guardian of his solitude, and thus they show each other the greatest possible trust. So angularities, difficulties, not being able to trust should also be allowed to be expressed in this space if you want something else to grow up. So the end thought, and this is again another quote by Gibran, who says that love one another, but don't make a bond of love. Let it rather be a moving sea between the shores of your soul. Fill each other's cup, but drink not from one cup. Give one another of your bread, but eat not from the same loaf. Sing and dance together, be joyous, but let each one of you be alone. Even as the string of a flute are alone, though they quiver with the same music. And this is where the title gets justified. If it has to be a symphony and harmony, we have to sing different notes. We have to sing through different instruments. So for the pillar of the temple, stand apart, and the oak tree and the cypress grow not in each other's shadow. With this, I conclude. So thank you for patiently listening. Yes, sir. Better.
Thank you, Madam. I think a wonderful presentation, a topic which we can deliberate over a week. You presented in a nutshell.
I tried to, but
touched upon the basics. And I know this is a topic which is very close to your heart, and we would choose some other opportunity where we can have a more detailed deliberation on this.
Sure, sir.
And really thankful that you took your time on a Sunday to come and
Thank
join
you,
us.
Sir. Thank you. Pleasure was mine. Thank you.
And I will request please.
This one, right?
अच्छा शुक्रिया सर.
And on behalf of the Center for Childhood Small Children. I know we would have loved the discussion. It goes on like this.
So, after that thought-provoking session, which I'm sure has generated a lot of questions in your mind, we keep on discussing that on day-to-day basis, but let's go ahead with our academic program. Now we have the first session will be taken by Dr. Rajni Farmania. And for this session, I'll call upon the chairpersons, Dr. Shikha Mahajan. Dr. Shikha Mahajan is Associate Director of BLK Max Hospital. And Dr. Monica Juneja, Head of Department of Pediatrics, Monarjad Medical College and LNJP Hospital. And I request the chairpersons to introduce the speaker and the topic, which is cerebral palsy mimicus. Over to Dr. Shikha and Dr. Monica.
We have Dr. Rajni with us, Dr. Rajni Farmania. And the only thing I can say about Rajni is that she is very, very hardworking, very sincere with her work, and she spends a lot of time with her patients, which is, I think, very important in neurology. The rest of her academic details, I request Dr. Rajni to introduce herself, self-introduce herself.
Okay. So thank you, ma'am, for these nice words for me. And regarding my academics, I have done my MD Pediatrics from SMS Medical College, Jaipur, and that was in 2008 till 2011. And then I did my SRship at AIMS 3 years, and then 3 years of DM Pediatric Neurology. And after that, for past 4 years, I have been associated with BLK. And I've been privileged to work in a very nice and a very good department where I never had any problem in terms of teaming up or gelling up. So I think with this, I'll start my presentation today. Today is an important topic in terms of clinical neurology. And I would discuss some cases which had been referred to me as a case of cerebral palsy. And then when we further investigated, they came out to be something else. So this is day in and day out cases and very rare, I would say rare, but very important for us to know. So just to have a brief definition and overview of the case of the cerebral palsy, it is a group of permanent disorder of movement and posture, and that is non-progressive. The disturbance has been occurring, had occurred during the developing brain or immature brain. It can be accompanied by disturbance of sensation, perception, or multiple other factors. But the point here is it is permanent, it is non-progressive, and it would have been happened during that immature stage of the brain. So let's start with the case. The case is a 6-year-old child. The child presented with delayed attainment of milestones, difficulty in walking with progressive decline over past 8 months. The child was born as the third gravida with a non-consanguineous marriage. The elder sibling was 9-year-old child. She was girl child and alive and healthy. Second gravida was a spontaneous abortion. This child was born IUGF. He cried immediately, but had a episode of symptomatic hypoglycemia at 12 hours. Child was admitted in an ICU for 8 days for this neonatal issues. The child had mild developmental delay. He started walking on toes at the age of 2 years. He started speaking at the age of 3 years in sentences. And now at 6 years, he can walk independently. He was partially dependent for activities of daily living, and his social quotient was around 75%. For his physical profile, he had spasticity. Basically, there was stiffness in both the lower limbs, the upper limb and the trunk was normal, and there was no diurnal variation for the spasticity. So this is the detail of global developmental delay. Again, that the child had mild delay, child had caught up, but at 6 years, there was deficiency in both physical profile as well as socio-cognitive profile. He also had mild hyperactivity and inattention. Stiffness I've already introduced. And on examination, child was stunted, child had wasting, also child had microcephaly. Child had bilateral calf hypertrophy as shown in the image, though cover sign was negative, and spasticity was observed in both the lower limbs with brachydactyls and clonus. So let's have a look at the video. This is a child who is able to walk independently and he is walking on toes. And the third video was when we admitted the child for Botox injection. So walking independently, and in this picture we cannot see the head size, but the head size was also low. So discussing the case further, since the child had some neonatal issues with the motor delay, we suspected yes, the child could have had cerebral palsy. So MRI was done, which showed some non-specific shadows only on this one, mild hyperintensity in the right frontal area, periventricular region, but there was no sign of periventricular leukomalacia. MRI spine was normal. Since the child only had problems in the legs, MRI spine was done, which was normal. Total CPK was mildly high. SGPT was also mildly high. So case summary, the child had progressive spastic paraparesis, motor delay with a progression for past 8 months. He had intellectual disability, he had microcephaly, bilateral calf hypertrophy, and non-specific MRI changes. So the history and the examination did not match a case of cerebral palsy because there was progression and MRI was not also supporting the clinical finding. At this stage, multiple differentials were kept. One was cerebral palsy, of course, but then the MRI was not suggestive and it was progressive. DMD was also kept, but proximal muscle weakness was not there. Metabolic disorder, hyperargininemia could have been there, but though this was a very rare case and the child did not have any aversion to protein-rich food, that was a point means. Child could have had some other genetic disorders, could be a case of primary dystonia or hereditary spastic paraparesis. So with the differential, we went ahead with the metabolic investigations. Blood lactate was mildly high. Blood ammonia was also mildly high. We went ahead with TMS, shows elevation of arginine, and these were the levels. The arginine level was 245. The cutoff was 54. So this was at least 5 times raised arginine. And then we did JCMS. Here we got orotic aciduria, which was 44-fold high. So high arginine and increased orotic acid level in urine. So just a brief update on urea cycle defect. This is a urea cycle where we have 6 enzymes and 2 transporters, and ammonia is processed through this cycle and excreted as urea. The last step, the last year in this cycle is arginase. So whenever there is arginase deficiency, arginine will rise. The other enzymes, if there is a defect in other enzyme, then arginine is low. This is a cartoon which shows that whenever the defect is in here, carbamyl phosphate, it goes in a different pathway and orotic acid is produced. So to differentiate between 6 enzymes deficiency in urea cycle defect, we can see that arginine plays an important role along with uric acid. Most of the disorders will have decreased arginine. Only arginosuccinic acid lyase deficiency in arginase will have increased arginine, and arginine will be very high in arginase deficiency because that is the last enzyme where arginine is getting processed. And orotic acid is very high in OTC. So with this thing in the mind, the case was suspected to be a case of hyperargininemia. We went ahead with, okay. So the clinical differentiation, in the case of urea cycle defect, mostly the cases presents with lethargy or hyperammonemic encephalopathy in a very young age. This is the only urea cycle defect which presents as a slow and a delayed development. So mostly they come with protein intolerance, they have spasticity, they have seizures, they could have irritability. So multiple physical signs as well as socio-cognitive signs along with elevated arginine, lactate, and CSF vitamin. So we went ahead with with the genetic testing, and we did get the mutation which proved the diagnosis of hyperargininemia, arginase deficiency. And here, when we asked the father again, he told me that this is a 10-day. This is a newborn screening report of a 10-day-old child, where again arginine was very high. It was 285. The cutoff was less than 132. See, even this child had the finding even at the newborn screening at 10 days of life, but was not followed forwards. So literature review. Hyperarginemia is a rare autosomal recessive metabolic disorder which is caused by the deficiency of arginase 1. It is a rare disorder, 1 in 2 million. The common phenotype is very different than other urea cycle defect. Hyperammonemic encephalopathy is not there. They usually come with spastic paraplegia, cognitive deficiency. They can have epilepsy as well in childhood, and they can show a very slow progression. Because of the arginase deficiency, arginine is high and it causes oxidative damage because of the shifting to other metabolite, the increased level of nitric oxide and guanidino compounds, and they alter the GABA neurotransmission. That is how they get the seizures and epileptogenic effect. So seeing a case series of 16 patients, it shows that the mean age of onset is around 3 to 5 years. So mostly cases are diagnosed around 3 to 5 years, not an early age of presentation. The variability can be very mild to very severe, and they can also have socio-cognitive profile, which is also very mild to severe. So physical and socio-cognitive profile, which can have a huge variability from mild to severe cases. So this is a single center cohort, a 21-year retrospective study where again the mean age of diagnosis was 3.3 years and seizures were there in around 50% of the cases. Non-specific MRI changes were seen. Arginine levels were universally elevated throughout the follow-up. And these children have a difficulty in management. It is not so easy disease because dietary restriction of protein, that is arginine, along with providing other essential amino acid is a challenge. And then preventing metabolic decompensations of hyperammonemia with scavengers is another way to treat hyperammonemia. So the learning point here is spastic paraplegia can have many differentials other than cerebral palsy. History and MRI will give the clue that it is a mimic. And metabolic disorders, though it is rare, it is worth considering. And appropriate management at early age, since this child had finding at the 10 days of life, we could have followed and maybe the disease course could have been a different one in this case. So moving forward to case 2, this is a 9-month-old child who presented with delayed attainment of motor milestones. Socio-cognitive milestones were normal. There were no history of seizures. In the birth detail, the mother was a gravitas 6. This was a gravitas 6 child with a history of 4 consecutive miscarriages in first trimester. The birth detail was okay. He was a 2.4 kg child. He cried immediately. He had neonatal jaundice, but was not admitted for phototherapy. Now, family history was significant. There was an 11-year-old child who was alive and healthy, 4 consecutive miscarriages in first trimester, and 1 girl child who was a distant cousin. The child had a neuroregression at the age of 4 years and expired at the age of 11 years. This child had predominant motor delay. Socio-cognitive was apparently normal for the age. Let's see the video. This is a 9-month-old child who was alert, active. He also had babbling, and he's not able to turn over. He has abnormal postures of both the upper limb with intermittent fisting. And we can see that he has rigidity in both the hands, some kind of dystonic posturing of both the hands in both the videos. Head size looks okay. So he had predominantly motor component with the extrapyramidal features upfront rather than spasticity. So here the possibility could have been a dyskinetic cerebral palsy because the child had history of neonatal jaundice but was not admitted. The other could have been a metabolic disorder, could be glutamic aciduria or mitochondrial disorder, or could be some other genetic disorder. So here again MRI was done, which was normal. Other routine blood investigations were normal, but uric acid was very high, which was alarming, like 8 mg per dl. Usually in this age, for an infant, the uric acid is around 2 to 3 mg per dl. So here, if you look into the differentials of uric acid abnormality, most of the cases, these are the 4 disorders where it gives a clue for a presentation for a child with neurological disorder, mostly will have a low uric acid. And Lesch-Nyhan syndrome only will have high uric acid because of the metabolic pathway. They will also have a high excretion of uric acid in urine. So looking at the pathway here, this Lesch-Nyhan syndrome is a disorder of a purine metabolism pathway. Purine metabolism is involved in a nucleotide biosynthesis by 2 mechanisms. One is de novo synthesis, the other is a salvage pathway. In terms of brain or a neurological feature, salvage pathways become more important because neuron regeneration do not happen. They depend mostly on the salvage pathway for manufacturing of DNA and RNA. Here, the most important enzyme is HGPRT, which actually salvages guanine and hypoxanthine to form GNP and IAP. So whenever this enzyme deficiency is there, hypoxanthine and guanine salvages do not happen and xanthine is overproduced, which leads to the overproduction of uric acid. So we went ahead with the genetic testing and finally we got the mutation positive as a case of Lesch-Nyhan syndrome. This case was rare because this child did not have, as we all know that Lesch-Nyhan syndrome will have self-mutilation or something that usually comes a little later by the age of 2 years or 3 years. The pathophysiology here is that relative deficiency of GTP will lead to the increased dopamine receptor activation, and that is a probable mechanism of having all the extrapyramidal features in a child who is an infant. So they usually come with hypotonia, they have developmental delay, extrapyramidal features, that is action dystonia is seen after 8 months of age. They can have choreothetoid movement, they can have other movement disorders. The typical self-mutilation syndrome, as we all know, starts after the age of toddler, after the toddler age group. So if we put Lesch-Nyhan syndrome, presentation in infants, the most common presentation is a renal presentation. They present as renal insufficiency in infants and also in neonates. A 3-day-old child had been presenting with acute renal failure. So mostly the presentation of a Lesch-Nyhan syndrome is because of the hyperuricemia, the renal pathways. The neurological features are not much discussed in this age. So learning points here was a normal MRI of a child who had developmental delay with extrapyramidal signs must be investigated, and uric acid is an important and a simple screening test in cases of developmental delay. So a case 3, just a single slide. This is a 3-year-old child who presented with socio-cognitive delay, basically global delay. Socio-cognitive was more predominant than motor. And the father came to me with right leg monoparesis, that the child is not able to walk properly. He was not much concerned about the socio-cognitive thing, but on examination, child had autistic features and she had a typical kind of stereotypy. Midline hand, stereotypic behavior, microcephaly. So we went ahead with the genetic testing, and actually the midline stereotypy is a girl child, microcephaly. This pointed towards the genetic disorder. The genetic syndrome was identified as a case of Rett syndrome. So the message here is all children with motor delay with abnormal tone are not cerebral palsy. And here are some pointers which will tell us that this is a CP mimic. One is absence of family history, absence of history of perinatal risk factor, a family history of sibling with a similar disorder, any motor symptom after the initial period of normal development, or if there is a developmental regression or progression of a neurological sign. If you feel there is a marked fluctuation of symptoms or a clinical exacerbation, basically in a febrile illness is pointing towards a catabolic state, a mitochondrial disorder. It could be isolated generalized hypotonia. Many congenital malformations comes only with isolated hypotonia. They can have predominant ataxia. So signs of peripheral neuromuscular disease, basically DMDs and all also are being referred as cerebral palsy. So neuromuscular disease can also present as a mimic of cerebral palsy. If the child has predominant eye movement abnormality, then also other differentials should be sought. So when you suspect the case of some genetic or metabolic disorder, you have to first identify whether the child has predominant spasticity or you have a predominant dyskinesia or ataxia. So there is a whole list which goes this way, that what is the predominant neurological symptom along with the developmental delay that will hint the diagnosis. And this is a basic approach flowchart which shows first you take a history and examination, which is inconsistent with perinatal injury. And then you do MRI brain plus minus spinal cord as required. The main point here is you should identify it is spastic or it is dystonic or it is ataxic, and then you will do this set of investigations, that is basic thyroid, uric acid, amino acid, lactate or pyruvate, acyl kinetics. Basically, this is the whole metabolic profile, and then you go ahead with the genetic testing as required in the case. So key takeaways are, all cases of motor delay are not always cerebral palsy. Investigate cases where the history is atypical. Predominant signs should be identified and MRI will give a clue. Judiciously investigate the cases for metabolic and genetic etiology. With this, I'll end.
It was from your daughter, the last picture. It was from your daughter.
Yes.
Yeah,
Very nice.
Right.
ask a question?
Yeah.
We newborn, when we have either cycle defects as a suspicion, we always start arginine as a therapy. So is it a rule that arginine deficiency is never built in newborn and never built in pneumonia cycle defects?
No. They do not present with encephalopathy in that newborn period. They are diagnosed, they present as spastic periparesis in a later age group.
Because we use arginine as a L-arginine as a therapy in all individuals. So I'm just curious to know that what patients, those patients who come to you as a neurologist, do you investigate all of them with this?
No, when the history is typical. In this child, the first child had a progression over 8 months. The child was frequently falling and the child was not able to, go towards the motor functioning was deteriorating. So that was a point. Another thing, MRI was not supported. Though MRI was referred as some signal changes periventricularly, but that did not show any periventricular leukoinnovation. Also, a history of hypoxia was not there. Some hypoglycemia was there, but hypoxia was not there. So there was some mismatch. And then I went ahead with metabolic testing.
So parents themselves came to you, or the pediatricians referred that?
Pediatricians referred.
They're not fitting into it.
Calf hypertrophy also confused me about. So spasticity, basically the message is spastic muscles are weak. So when they are overused, also they can have some kind of calf hypertrophy. Calf hypertrophy always does not mean DMD. So even spasticity, spastic paraparesis, children can also have
Yeah, there is a whole list of
yes.
causes of calf hypertrophy and even Gowers sign. So, that is why Dr. Rajni is justifying the time she spends on the patient. In neurological cases, I think everybody is already scared that cerebral palsy patient has come. And she has added another twist that it is not just cerebral palsy. You'll have to go ahead and look at other things also. So very nice cases. And I think those of us who are diagnosticians who like to find out what is happening, every child is a puzzle. If you look at things like that, things are very interesting, and you will, if you are looking at smaller things, clinical clues, you will definitely be able to find out these rare diagnoses. It is not that you cannot pick them up, but yes, you have to be a clinician first. You have to sit with the child. You have to look at atypical findings in the history and examination. And even though Dr. Rajni was talking about the MRI not being, you can have typical, say, some changes. Say you can have cystic encephalomalacia. Still, it may be something else, like sulfite oxidase deficiency. So there are rare causes. So MRI does not need to be known. Even with abnormal or corpus callosum, agenesis, and all those things, you may have a metabolic cause for this presentation. But very nice cases. I think if there are any...
The first child would have been started on treatment at 10 days of life, suspecting all this. We have special formulas for this newborn at 10 days with arginase deficiency.
We just monitor ammonia. The ammonia is very high. And
arginase deficiency.
Arginase deficiency. Arginine was high. We could have done the dietary modification.
Like?
Decreased arginine in diet.
Breastfeeding. Baby's breastfeeding. 10 days.
So I think we would have monitored ammonia and then...
Because the typical cycloanemia, OTC and all, we have special formulas. I'm not sure about arginase.
No special formula. And a child being known at the 10 days of life, that is also first experience to me.
Once you diagnose, what did you?
We actually already at 6 years, there is no much role of the dietary management. Also of his ammonia was also not very high, though I put him on sodium benzoate. He is on protein restrictions and we did Botox therapy. With that, spasticity is a little better. But I think so he will be able to progress it. But this spasticity would have been controlled if he would have been like on a dietary management.
Low protein diet.
Yes.
Thank you, Dr. Rajni, and thank you, Dr. Monica and Dr. Shikha Mahajan, for this very, very interesting. I'm sure each pediatrician should listen to this talk because we see cerebral palsy. And whenever a patient with cerebral palsy comes, we are in a hurry to refer it to an occupational therapist or developmental pediatrician and get your hands off. But I'm sure each pediatrician will be missing some of these problems. I'm sure we'll be wiser by this.
It is very important to pick them up. I'm sorry, I'm interrupting, but we have had cases wherein first case was missed and the sibling presented with similar illness and had a severe dystonic type of presentation. And it was glutaric aciduria and other causes which can be like devastating for the family because the initial diagnosis was missed. So we must always be for a lookout for atypical presentation so that the next child at least is not severely affected.
So
Thank you so much for inviting.
For this clinical meeting, we also will be having the recording which will be on the YouTube link of IAP Delhi. So we'll be circulating that also to those members who could not attend. I'm sure many more will be benefited by this talk. So also it will be circulated to everybody. So I request Dr. Bhasin to give from IAP Delhi. Small planter and a
Dr. Monica.
Thank you for joining us. Thank you so much, Dr. Shikha. Thank you, Dr. Shikha. Now coming to the second part of the presentation, and that's another very interesting session. So I request Dr. Vineet Sehgal. Dr. Vineet Sehgal is Senior Consultant, Max Hospital, Shalimar Bagh, and Dr. Rachana Sharma, Associate Director, Pediatric ICU, BLK, Max Hospital, to present us Dr. Naresh Lal, who's a presenter for respiratory distress beyond lungs. So I'll request Dr. Vineet and Dr. Rachana to take over and introduce. You can come here so that you're also visible at the time of introduction. Just one moment.
You will still be visible.
Either explain it. Dr. Vineet. Go to Dr. Naresh.
Sure. So Dr. Naresh is a senior consultant in pediatric critical care in Max Specialty Hospital. He is with us for last 6-7 years. He has done fellowship in pediatric critical care from Apollo Cherry Hospital, and since after that he had done his he was working as a pediatric intensivist from Mumbai, following which he has joined us since then he is a part of our team. And today we will be discussing a very interesting topic, that is respiratory distress. But this respiratory distress is something which is often seen in the emergency, and whenever a child comes with a respiratory distress, they are more focused on the lungs. So we thought about enforcing this this habit of looking at the patient as a whole, taking detailed history and giving a good clinical examination. So I'm really thankful to Dr. Bhasin for guiding us to choose this topic so that we can brush up our basics. Over to you.
Thank you. So we had two good professional talks. So I hope I can maintain the symphony of it. So
as told by Dr. Acharya, in a symphony you need a kind of
you all can be in tune with it. So I'll be discussing about, as Madam has told, about respiratory distress, but this we are not focusing on the ICU care of the cases I'm going to present. So it's just how to identify these patients, and it's more of a pediatric office practice. So So we all know that as per the PALS, respiratory distress is defined by the presence of increased rate of breathing and increased efforts of breathing. So you can be tachypneic and you can be having work of breathing. That's what defines the distress. But it can be simply an individual's perspective of some uneasiness in breathing. So that can also, the patient will be saying that he's feeling inconvenient in breathing. So that also points to respiratory distress. So the clinical features we have to look for in these kids are look for tachypnea, dyspnea, look for nasal flaring, look for chest wall retractions, look for any conducted sounds in the chest. Auscultation is very important. And especially in case of infants, head bobbing is a very important sign. It's a sign of severe obstruction, airway obstruction. If you don't recognize distress early, they can land up in respiratory failure, where there are, which is basically defined by changes in the cardiac system and the neurological system. So you could have marked tachycardia, bradycardia, hypotension, landing in arrest. And otherwise, neurologically, we have to look for whether the child is conscious or not. So the child can be lethargic, he may be unconscious, he may present with subtle seizures and coma also. If we talk technically, we have to do a blood gas and we look at your PaCO2 level. So any hypercapnia more than 50 and hypoxia, that is PO2 less than 60, will be a part of respiratory failure. So with this brief introduction, so let's see a few cases which we got in the emergency room. So this was a 7-year-old boy who was referred from another hospital, and he had a history of cough, vomiting, and difficulty in breathing for last few days. And when we examine this child in the emergency, we see that the child vitals are unstable. He is tachypneic, he is tachycardic, the pulses are weak, the capillary refill time is prolonged more than 3 seconds, but he's maintaining saturations and his blood pressure is stable. So when we do a systemic examination, we see that the child air entry is equal on auscultation. There is no obvious any stridor or wheeze, but what we noticed significantly that child was having effortless tachypnea. So I think that is a very important sign which we should not miss. There was no actual work of breathing, but the child had a silent tachypnea. And otherwise, system examination, cardiological, everything was fine. So before the pediatric resident was called in the emergency room, the CMO on duty saw that the child was tachypneic and he was having tachycardia. So he thought the child may be in a state of compensated shock, and IV fluid boluses was started, oxygen was started. And since the child was reporting a breathing difficulty, the child was put on continuous level nebulizer, and X-ray was ordered. So this was the X-ray which came later on, and the X-ray was normal. So the CMO called up the pediatric resident because he wanted to for the pediatrician to have an expert opinion. So by the time we came, the resident got a VBG done. And in the blood gas, we see that the child was having severe metabolic acidosis. The bicarbs are just 4.5, PCO2 is hypocapnic, and the lactates are normal. So there was severe metabolic acidosis was present in this child. And he did a blood gas. Blood gas was very high. It was more than 350. Sorry, blood sugar. Blood sugar was high, it was 350. So the clinical picture at this. It's coming here.
यहाँ भी आने चाहिए समझ आएगा ठीक है कुछ यूज पड़ा होगा स्टार्ट
So as I mentioned that in the case, the child was having effortless tachypnea, but the respiratory system examination was normal. And a clue to our diagnosis came from the blood gas. And finally, when we did RBS, the sugar was very high. And when we asked the history from the parents, they reported that yes, that the child was having a history of polyuria and polydipsia, and he had a weight loss. Over the last 1 month, the child had lost almost 8 kgs, and the child was complaining of frequent urination in the night. So we did a urine dipstick. Glucosuria was positive, and large ketones were found. So the diagnosis was diabetic ketoacidosis. So from this case, we learned that distress in this case was probably because of the metabolic acidosis, and it did not warrant the use of levolin and bolus, which can be detrimental in these cases. Okay. So case number 2, this was a 13-year-old male child. He presented with complaints of cough and cold for 4 days, difficulty in swallowing with vomiting for 2 days, and poor oral intake for 1 day. And at the admission, we saw that the child was quite anxious. He was tachycardic. Respiratory rate was 18, which was fine. But the child was not maintaining saturations at room air. And perfusion was otherwise good. Blood pressures were fine. So this was a child. The child was shifted to PICU, where it was seen that the child was having shallow respiration. And he had paradoxical breathing was present. So it was more of abdominothoracic kind of breathing. So the child was clearly distressed, was uncomfortable, anxious, and since he was not maintaining saturation, the child was kept on NRM oxygen, and saturation was maintained. We did a blood gas. We found out that the PCO2s were very high. PCO2 was 48, and we ordered a chest X-ray. So this was a chest X-ray. Probably the child had aspirated, and the chest X-ray showed a right upper lobe opacity. So in view of the presentation and the child not maintaining saturation and paradoxical respiration, the child was clearly in distress. So we had to intubate the child. And when we took a detailed history, there was history of change in the voice in the last 1 week. There was drooling of saliva, and the hoarseness of voice was present. The child also had ataxia and areflexia on examination. So with this, we made a diagnosis of neuromuscular etiology, probably Guillain-Barré syndrome, and it was probably a Miller-Fisher variant because the child had ophthalmoplegia, ataxia, and areflexia. We did a workup, CSF. There was no albinocytological dissociation because probably the case had come within the first week. MRI brain and spine was normal, and NCV gave us a diagnosis with the absence of HNF reflexes. The child was managed with the IVIG. And after 2 days, the child could be extubated, and the weakness improved over the next 1 month with the physiotherapy, and the child was discharged later. So in this present case, the cause of distress, there was no respiratory involvement as per se. It was because of a neuromuscular weakness, which had led to the patient aspirating the food contents and causing distress. So that has to be kept in mind. Case number 3 was a 7-year-old girl presented with fever of 5 days, vomiting of 5 days. She reported presence of high, very dark colored urine. And she had a breathing difficulty since 2 days. So when we examined this girl, she also presented in an emergency room with tachycardia and tachypnea. And she was not maintaining saturations at room air, so just 80% in room air. Her blood pressures were more than 95th centile for her age. And we noted that she had more famous arca on examination. And when we do a auscultation, we find out there are bilateral crepes in this, and the child had retractions present. The rest of the system examination was normal. So the chest X-ray was done. It was showing the presence of fluid in the lung, pulmonary edema. We did a blood gas in the emergency room. It showed high metabolic acidosis, normal and iron gap. So in the presence of this hypertension, with a history of presence of red urine and presence of generalized swelling, we gave a provisional diagnosis of acute glomerulonephritis was kept, and the child had hypertensive emergency with congestive cardiac failure and pulmonary edema. We asked any history of any impetigo or any rash or any burning micturition or similar complaints previously. There was no previous history. So we had sent up the workup for sepsis and renal etiology. So this was the workup. The counts were slightly raised. The kidney function test was deranged. The creatinine was 1.8. Urine routine was full of RBCs. And we wanted to check for albuminuria. So the urine protein creatinine ratio was almost 7, which is very high. And we sent other workups, C3. C3 was quite low in this patient, and ASO was elevated. So with all this, we made a diagnosis of probably post-streptococcal glomerulonephritis. And the child was managed conservatively. They just need an IV support to support their breathing because the child also had pulmonary edema. So an IV support in the form of BiPAP was provided. 1 dose of Lasix was given. And to control hypertensive emergencies, IV labetalol infusion was given, which was slowly tapered, and the child was put on oral antihypertensive. And subsequently, the child was fine and was discharged on day 4, and his proteinuria and hematuria resolved after a few weeks. Coming on to case number 4. So this was a 3.5-year-old female. She presented with some viral etiology, cough and cold for 3 days. And suddenly, like over the last few hours, she has become quite irritable and refusing to feed. And she was quite tachypnic. But there was no any history of any fever or loose stools or any vaccination before or any rash or any seizure history before. And this child was seen in the emergency room. The child had severe tachycardia, 184. The rhythm was normal. There was, I've not put the ECG, but there was no SVT noted in the emergency room. The respiratory rate, the child was tachypnic. Pulses were feeble. Capillary refill time was prolonged. The saturations were not recordable, and the child was quite hypotensive. Otherwise, auscultation, the child, there was no conducted sounds. There were retractions present, and on auscultation, there was a gallop rhythm present. And per abdomen, the liver was palpable. So we did a VBG. There was severe metabolic acidosis. Lactates were 6.5, bicarbs were 10. Otherwise, the electrolytes, the calcium, sodium, potassium were all normal. So this was the X-ray. Child clearly had cardiomegaly, and there was some fluid in the lungs. The child was resuscitated and intubated. And the provisional diagnosis we kept was viral myocarditis in view of the sudden presentations, and no other etiology was found. So we have done an echo. So the echo was showing severe LV dysfunction. The coronaries were normal, and the other pulmonary arteries were also normal. Basically, wanted to rule out L-kappa, which can present in this age. So that was ruled out. So it was a case of pure viral myocarditis. We proceeded with doing the enzymes. So CKMB was elevated, and TROPI also was elevated. ECG was normal. So while managing these cases, like these cases, we do frequently see them in the emergency room. And seeing such cases in the emergency room with the feeble pulses, the emergency physician may be tempted to give boluses. But this is one particular case where boluses will not be tolerated. The child can collapse on table. So absolutely no boluses for them. If you require, you can give 1 to 2 ml per kg of small boluses, and early anatropy is what they require. So if any, especially in case of infants, if they're presenting with cold clammy skins and it's a sudden history, a sudden viral history or a sudden acute history, you have to suspect a cardiac lesion and avoid giving boluses in these patients. So early intubation is required, early anatropy is required, and once you have taken control of the airway and the hemodynamics, you can start with vasodilators like milrinone or dobutamine, what is available. So coming on to the last case. This was a 4-year-old male who was referred from outside hospital with complaints of loose stool for 3 days, breathing difficulty for 1 day, and autosensorium since 1 day. And the child was seen in the emergency room. He was tachycardic, tachypnic, pulses were otherwise felt. Saturations were not maintained. We had to use an NRM oxygen. Otherwise, the blood pressures were fine. Chest was fine, no findings in the chest, but the GCS was quite low. It was 6. So the child had to be invasively intubated. This was the X-ray we had got. X-ray was absolutely fine. Blood sugars were normal, but a blood gas was done, which was showing high 9-gap metabolic acidosis. So 9-gap was 36. and the workup was normal. The child was not septic. Septic markers were negative. Echo also was normal. So we were thinking about the possibilities since the child had no history of any fever, so sepsis was ruled out. But the child had presented with the sudden onset of sensorium. Previously, the child was developmentally normal, and there was no family history of any sibling death like that. The LFTs were normal. We did a urine ketone because the child, the sugars were maintained, but we did a urine routine to rule out a metabolic disorder also in this. So the ketones we did in the urine was 2+, and because the blood gas also was showing significant metabolic acidosis with high NIN. So we wanted to rule out metabolic disorder in this. Not going into details, but if any child has metabolic acidosis presenting with ketosis and with normal lactate, as in this case, we have to think about possibility of metabolic disorders, especially in the presence of a high NIN gap metabolic disease. So we did an ammonia as per the workup, and ammonia came out to be very high in this child. So little surprising because the child, the LFT was normal. There was no previous history. The family history also was not there. But in the workup, the child finally came out to be as a case of metabolic disorders. The genetic workup is still pending. This was a recent case we have got. So the child was intubated, and the child was managed with CRRT, which is a very good modality for hyperammonemia in these cases. So the child improved, was extubated, and the child was managed with, otherwise the general management is with high GIR fluids, 25% dextrose, and you have to, in the diet, you have to avoid giving high proteins, and ammonia scavengers are required. As I said, TMS, GSMS is still pending. So the child was doing fine after 40 hours. So just take home message for today will be like every respiratory distress is not related to chest pathology. A good physical examination with a good clinical history will always clean the diagnosis and guide your further management. And in the diagnostic workup, blood gases are quite useful. So has to be utilized in all the cases. Okay.
So last case, check for B12 level.
You said this child and you also wondering what it is, since the child is in the developing state, and the child was passing a lot of fever. And we were, as we keep giving to its child's blood pressure will go up. And it was very difficult for us to think that what is happening to the child. So we just did ammonia, because when we saw this higher NIN metabolic acidosis, so we did ammonia, and ammonia was very high. So we by midnight we were able to start the CRT. So
once you start CRT, then all metabolites are.
So before it goes we also get what we do as per our general analysis. And
the older child propionic acid will not present. Melaminic acid in your acetic acid. Which at 4 years.
This child is very interesting history. When we look at history that at 2 years, like child was admitted to Shifu service. There also they have written this child had two stools admitted there, had a severe metabolic acidosis at that time, but they were from Sadar family. So they were advised to go for further research, but they have not done it.
Symptomatic melanoma.
That was interesting. And this time also the child had a loose fever around a week back for a day. This time they were sitting at home. They didn't go to any other hospital. So probably child got dehydrated was passing out. But still I was wondering that why child was passing out. Because probably the serum has become hyperosmolar because of hyperammonemia. Probably that is what it is.
One period they're going to air. Organic acidemia, all of them go to any comments?
Nice presentation, and I think it just reiterates the old conventional teaching that polycythemia and respiratory distress is not basically a respiratory system. You have to think of cardiovascular causes, you have to think of causes, and you have
or distress is not going to respond to levocetibutamol nebulization. And if the child does not respond to levocetibutamol nebulization, the next step is not to do a beauty-rod nebulization. Automatically. See the child. Unfortunately, nowadays the assessment of the child when you walk into the emergency is just a pulse oximeter and a chest X-ray, and you kind of start treating the child as either a V or as a pneumonia. So I think it's more important for the residents that they have to do an overall assessment of the history and the clinical examination, because respiratory causes, cardiovascular causes, neurological causes, metabolic, septic causes, all that has to be considered.
I want to share one case. I won't forget that case when I was in So this morning in the night, the child is coming there in emergency and the child is very nervous. Basically, child is a visa. He was an adult. He came all the way running from my home. And when I went upstairs, child was already shifted to place. I auscultated the child. The child, the chest was absolutely clear. Basically, chest is completely clear. मैडम मुझे बहुत एडवाइस किया नीचे बच्चा फिर उसका ब्लड टेस्ट देखो थोड़ा सा इकोनोसिस आ रहा है उसका कैल्शियम को देखा कि कैल्शियम उसका कम so basically that child turned out to be a case of functional disorder बच्चे को ब्रेकअप हो गया था बच्चे का ऐसे में टेक्नी हुई और पास ही होगा और बच्चा
एक बार कमेंटेबल है क्या भागते हुए भागते हुए आओगे हमारे लेफ्ट
complicated nephrotic syndrome with more complication of pulmonary thrombosis also present with
Cardiovascular. Yes. Cardiovascular में इन्होंने जैसे hypertension present किया, but undiagnosed congenital heart disease can present with the LPF or certain.
So I have some two cases.
One is you have to think of other systems also.
That was the idea behind the presentation.
Yes, chest auscultation is a very important. I still remember I was senior resident in stage 2 and sent one patient for admission. 6 months old, 9 kgs. So, cannulation was somehow I was in the habit of doing blood sugar every time I did the sampling. So, I just did anti-stabilizers. She did the RBC, it was 500 and something. This is just let's repeat. Because it was like sir said from the clinic in the evening and it was 8 o'clock in the night. Clinic started at 8:30. And typically bronchitis are of the sound of the skin. So we repeated the blood sugar again, which was starting to be
इसको बंद कर दे शॉप शेयर को thank you so much. We have come to the end of today's meeting. So before we give the some mementos from IAP Delhi, again 2 things from my side. The pediatric conference of North India is on 29th and 30th October. So everything is done from our side. Now it is time to register and to block your dates for 29th and 30th October. It is going to happen at IAP Centric, which is in Janakpuri. 1. Second is Happy Father's Day. I'm sure all of you, many of you. So the Mother's Day and the Women's Day are celebrated with much more enthusiasm than Father's Day. So let me complete my duty of saying that fathers are as important as mothers. So symphony between father and mother. So with this, thank you so much. And now we have the present duty to present mementos from IAP Delhi side. Please, Dr. Vineet and Dr.
The ratio of course.
नरेश को फिर रिपोर्ट भी देना है। नरेश ये हमारे पास कुछ पेंडिंग है, कुछ पेंडिंग है।
तुसी कुछ बयान देना है?
So maybe some members actually or members allow strength of any association is membership. So please ensure that all your associates become members of IAP.
आलोक हो यहाँ पे कुछ नाम बोले अच्छा नहीं लगता।
No meeting is complete without the host. So the most important person is Dr. Basim. So go outside.
This is the whole department of just
College times so 77. Wow. I कब से पढ़ा है? हमें जितना आता नहीं आता
ये नहीं की वजह से नहीं आता।
So let's have a big clap for all of us. On Sunday, all of us are here to celebrate this monthly meeting of IAP Delhi. So thank you so much, and I hope that we keep on getting again with other physical events as well. I'm sure now NTEP, the National Tuberculosis Eradication Program of CIP program is being held on 3rd of July. That is happening in East Delhi. So those of you who have not done an NTEP program before, please register yourself and you can contact Dr. Ajay Gupta and Dr. Puneet for the same. Apart from that, I think South Delhi is also in the process of doing bowel and beyond the pediatric gastroenterology program. So get in touch with Dr. Mamita and Dr. Shalini for the same. I'm sure keep on looking at your WhatsApp and a lot of groups. So we keep on sharing information. If you give this little bit of thumbs up, it helps the organizers to send more information to you. Thank you so much.
Thank you. Congratulations, Dr. Pankaj. Congratulations.
You want to say
for organizing a physical program.
No.
Just wanted to thank you for kind introduction that I'm also Deepika Saraf. I mean, I have been a pediatrician for a long time, but after that, I also had the chance to be a community medicine person. I did my doctorate in community medicine for days. And so I bring the combination of pediatrics and public health. So I was also after that associated with the ministry for quite some time. Was a part of the first associate advisor to the immunization technical support unit and at the ministry, and entirely the National Technical Advisory for Immunization, Dr. N.K. Arora and his team. And so I think we do, I mean, it was very, very good to see the intellectually stimulating environment in your pediatric center, which is not so common in other corporate hospitals that I know. I worked in Fortis and very closely associated with Apollo, but I've not seen this kind of, I'm very happy.
Very fortunate.
So, I mean, I like to say that, I mean, you're doing some great work here inside the hospital, but there is a need for some public health kind of work, which people should know that this is being done. And that would improve the credibility of all the people who are working here. Because, you know, we have this kind of a perception in the society that, you know, doctors are doing this and that, and they do the profit and whatever. So, but they have to know that we're the most ethical professionals in the country because we are monitored so strongly. But still we are the brunt most of the time. Thank you very much.
Thank you. Thank you so much. And for the timing, bye-bye. We'll see you again for the next physical meeting. Thank you.
Stop them. Stop up.
By